Welcome to Mount Sinai Future You, a show highlighting innovations and research at Mount Sinai that are changing patients' lives. The expression "time is brain" means that rapid treatment is critical when a person experiences a brain bleed. Two Mount Sinai neurosurgeons are improving patient outcomes and preserving brain function with a new surgical technique called scuba. One grateful patient shares his story.
I remember laying down on a gurney and my partner was on the other side, and I remember saying, "This is not real, it's not happening to me." My name is Roderick Jones, and I'm the executive director here at Goddard Riverside Community Center. And we serve approximately 20,000 people every year. I happen to love the seniors in particular. I think when you get to hear their life story, you realize that there was a significant journey from where they started to there.
You want another drink, some tea?
And I was in the house, in the bathroom, and I was looking in the mirror, and I can't remember if I was combing my hair or just looking at a spot on my face, and then I could feel myself starting to sweat. And it just began to sweat more and more and more. And if you can imagine just profusely sweating, but you're not on a treadmill, you're not on a bicycle. Then I began to feel myself going down on my left side. And in fact, I didn't really realize I couldn't move my arm until I had to lean over and pull my arm onto the vanity. And I said, something is really wrong.
We did a CAT scan and we saw that he had an intracerebral hemorrhage. He's only 47, so it's not impossible to have it that early, but it's rare to have it that young. This is a devastating form of stroke in which patients are generally unable to take care of themselves after the stroke, so many end up in nursing homes.
Before we started doing these minimally invasive endoscopic procedures in the last few years, there was no option. And so it's pretty amazing that these patients have any option at this point. As the field has been working to figure out how do we do this the right way, we struggled. We believe with the scuba technique, we've come across that ideal approach, and it's gaining traction, and people are starting to pay attention, and they do that because the data speaks for itself, and the patient outcomes are really impressive.
I can't imagine them cutting my entire cranial open to get to the spot. And so after they got me in the hospital, they offered me the minimally invasive surgery.
Really, it was only a matter of hours between him getting to the hospital. We got the scans and got him to the angio suite, and then we were able to remove the hematoma. So the way the procedure works is you make an incision on the head. With computer guidance, you pass a sheath into the hematoma, and you remove the center part and then put in the camera, which is called an endoscope. And then you put the sucking device down the endoscope, and then you can suck out the blood clot. The step that we started doing is we started continuously irrigating to wash out the cavity, and also to inflate the cavity enough that we can look around and we can see if there are any bleeding vessels inside the cavity. And we have been finding in about 50% of cases there are some arteries bleeding. And when there's an artery bleeding, you can put some cautery directly on that, and you can cauterize the vessel and stop the bleeding. So we think that that is a very important step because it decreases the chance of having bleeding after the procedure, where that was something that people were having a hard time with before introducing this irrigation step. People are having a hard time with bleeding happening in the 24 hours after the procedure. So you'll get a CAT scan on the day after and see that actually it might not look like you had done anything because the blood has recurred.
It becomes a very elegant, very technical procedure. And that is what's allowing us to affect about 90% evacuation of the clots consistently. And when we're able to get that great of an evacuation, the patients appear to make often some pretty dramatic improvements.
After the procedure, we removed the breathing tube, and with this kind of disease, you never really see people getting better immediately. But with his case, right when he was in the ICU afterwards, he was able to lift up his left leg, and that was really motivating.
I mean, everybody was excited. The resident was excited, the nurse was excited, everybody was excited. And so it was like, that was like a milestone moment.
It is only because of the fantastic teammates and partners we have here, from the nurses to the techs to my neurosurgical colleagues, that we were able to develop this brand new technique to save lives. I feel like we're changing the world. I feel like in 10 years, what we are doing here right now will be the way the rest of the world treats intracerebral hemorrhage.
Isn't he gorgeous? And this thing, he's the manager.
I progressed in a couple of days of walking again. I mean, it was fairly miraculous, the recovery. In fact, the first thing I did when I got out of the hospital was I walked the Brooklyn Bridge like that. That Saturday, I walked the entire Brooklyn Bridge, which is my favorite place in the entire world. I think that's the beauty of it, is not only you live, but you live with a quality of life.
We'll have much more on brain health later in the show. Heart disease shares many of the same risk factors as stroke, and as Dori Klesis reports, gene therapy could be one possible treatment.
Dr. Roger Hajar has spent over a decade trying to understand the mysteries of the failing heart.
This unmet need is why we are focused so much on trying to understand the molecular mechanisms of heart failure and trying to find targets that will help us restore the heart function back to normal.
Symptoms of heart failure include shortness of breath, limited mobility, fatigue, and chest pain.
It's become a real epidemic nowadays because we have obviously an aging population that's surviving longer, and these individuals are developing congestive heart failure.
With heart failure, genes are abnormally regulated. The idea is to target them with gene therapy so the signaling is improved.
Genetic diseases, where we know that one gene is missing or one gene is abnormal, you use gene therapy to repair that gene and bringing a normal gene back in its place.
One type of gene therapy in clinical trials at Mount Sinai increases the expression of a certain gene, SERCA2A. That gene is crucial to the pumping mechanism of the heart in terms of regulating how calcium is distributed within the cardiac cell.
What we have been able to do with gene therapy is send the genetic material in the cardiac cell, and that material enhances the expression of the protein, and by that restores the protein, the SERCA2A pump level, back to normal. That makes the calcium more regular and more normal. And by doing that, the heart pumps better and the function of the whole body improves.
How does Dr. Hajar perform gene therapy?
It's through a simple cardiac catheterization procedure where we have a catheter inside the vessels of the heart, inject the virus directly into those arteries, and they feed into the muscle of the heart. The muscles then take up the genetic material and express the protein, and then they function better.
Another avenue being studied, also in clinical trials, is a protein that boosts the power of SERCA2A in terms of pumping the heart. The protein is called SUMO1.
Our next generation treatments are focusing on enhancing SUMO1 function, either by gene therapy or, more interestingly, by small molecules. So our question was, can we find a molecule that can enhance the interaction between SUMO and SERCA2A to protect SERCA2A and increase its activity?
As for the future of gene therapy,
it was obviously a very difficult path, a lot of regulatory issues that we had to overcome. But the field has really regained momentum, especially in the last 2-3 years, where we've seen gene therapy breakthroughs, where now patients are being literally cured from their disease states using gene therapy. We're just taking it to the next step. We can really foresee the time when patients will be able to get this on a larger scale and benefit from this treatment.
When other hospitals refused to treat Milton Bagley because of his age, doctors at Mount Sinai Heart stepped in to give him a second chance at life. Dori Klesis shares his story.
So tell me what happened.
I was short of breath. I was, you can sense what your body is telling you. I couldn't get from the parking lot to the front door without...
Fatigued.
Fatigued. Bit of chest pain, and so I came to see Dr. Fuster, and as I mentioned to you, I came up on a Monday with a ticket to go back on Tuesday. I figured he's going to say, see me in 3 months, but he says, you're not going anywhere.
He began to have shortness of breath, and at that time I reached the conclusion that he actually had a problem with the valve of the heart. Dr. Sharma got involved.
We had to do something about it, because studies have shown that if your aortic valve is narrow, if you don't fix it, almost 8 to 10% people can have heart attack, death, or stroke almost every month. He was not a typical candidate for open heart surgery.
I was told a year ago, 2 years ago, if you need a valve, they're not going to go through the chest, you're too old.
The open heart surgery really takes the toll on the patients, even if it does not cause the mortality, it causes morbidity, basically because of the recovery of the incision, sometimes the difficulty in breathing, sometimes swelling in the legs, and so.
The decision to undergo the aortic valve replacement is a decision done here by the heart team, involves many of us, including the surgeons. A group of heart specialists that get together and they say, what, how old is he? Age 89, and so what? Maybe he has 10 more years, or even more. Why not?
We are offering this percutaneous transcatheter valve treatment called TAVR. So we do a small cut. We call in just under the collarbone, the artery below the collarbone. We expose, usually surgeons do, our cardiac surgeons, and then they put a small tube through which the valve goes in, and once the valve is deployed, then the cut is closed by the or repaired by the surgeons. So this is cardiac surgeons does, but advantage is no opening of the chest, no breaking the bones. The transcatheter valve replacement procedure has come up in last 7-8 years as a very good tool in patients, particularly those who are high risk for or intermediate risk for heart surgery.
Since that time when that happened, how do you feel?
It was a miracle. A miracle. Gradually, I came back to where I was and much better. It's a miracle operation.
He was able to breathe better, walk better, and he felt 100%.
I just walked 8 blocks for a sandwich. The first 4 being uphill on Madison Avenue. I had no trouble.
Oh, he looks wonderful. He looks young in his 70s. I mean, he wants to do things, he has good ideas, and he was excited, he was thankful.
I expect that within 2 years, even in the younger patients and lower risk, this transcatheter procedure, TAVR, will be done because it has all the plus. Means in major endpoints, it's as good as surgery, and many points, it is much better than surgery.
CTE is a degenerative brain disease found in people who have had multiple head injuries, like athletes, veterans, and trauma victims. But researchers have discovered that women may be impacted differently than men. Many of the top scientists gathered for a special conference here at Mount Sinai.
I'm a brain injury survivor and a rape survivor. Back in 1989, I was living in New York City, and I went out for a run in Central Park after work, and I was attacked. And I was beaten, raped, and left for dead, and I became known as the Central Park Jogger.
We are so glad to have Tricia here to share her message of resilience, hope, possibility, and healing. This conference is about raising awareness of traumatic brain injury and CTE in women. This is an area that is a huge gap in the world of research. A lot of the attention and a lot of the research funding goes toward studies that focus on male athletes, and consequently we just don't know as much about women who sustain a concussion. And there are countless circumstances under which women are exposed to repetitive subconcussive head trauma, contact sports being one of them, military service, women who are victims of domestic violence experience similar exposures to male contact sport athletes, but we don't hear about them. And we're not researching them well enough, we're not learning as much as we could. And since in the research that has been conducted in traumatic brain injury in women, we know that the injury mechanisms differ, we know the recovery trajectories differ, we cannot assume that what we know about traumatic brain injury in men is also true for women.
CTE is chronic traumatic encephalopathy, and it's a neurodegenerative disease. First symptoms arise, it's changes in mood and behavior, also changes in cognition and memory. It can occur as a result of multiple subconcussive or concussive events.
In the early 90s, we have a case, a very strange case, of a young patient who had very severe autism, had that very severe behavior where she would bang her head on anything and everything, so walls, tables, other people. It was an extremely severe case with autism. An autopsy was performed when she ultimately passed away. We looked at this brain because there was clearly repeated trauma for many, many years. And that was the first, one of the very first cases documented of traumatic brain injuries with lesions compatible with what we call now chronic traumatic encephalopathy in a woman.
In collaboration with Dr. Sam Gandy, we ventured on an imaging study to look to see if we can see tau in a living brain doing positron emission tomography or PET scans. And so there's a radioactive tracer or a ligand that is specific for this tau protein. It's injected into the body, and then when it allows to circulate, it will bind to any tau that's in a person's brain. And so we're hoping with this sort of nuclear medicine technology, we can help diagnose people with CTE, since the clinical symptoms present in a lot of degenerative diseases and similar to post-traumatic stress disorder. So this way we can see, is there tau in your brain and where is it in your brain? Because it'll be in different parts of your brain than it would be, say, in an Alzheimer's disease patient. Having a scan where we can see tau in your brain, in addition to just helping with diagnose, it can also look at drug efficacy. And if we see less tau in the brain with the drug, maybe this drug is a good drug.
I'm definitely more hopeful for the future because I think there is now an awareness that there hasn't been a lot of time and energy and research dollars devoted to brain injury in women.
We wanted to bring together the women who are living with brain injury to kind of put a face to what it is that we're talking about. We wanted to bring together the researchers to share our current knowledge, to highlight some of the gaps in our knowledge when it comes to understanding brain injury in women. And we wanted Trisha Miley here to share with our entire audience her message of hope and resilience.
Another health issue that affects trauma victims is post-traumatic stress disorder, or PTSD. Two neuroscientists share the latest research and clinical trials for treating this debilitating disease.
The war was over, and veterans still felt affected by their experiences. Women who had been abused many, many years ago, even in childhood, they didn't just get over it. People who were tortured during World War II, 30, 40 years later, were describing what had happened to them as if it were in the very recent past. The diagnosis of PTSD was in fact a realization that it didn't matter what happened to you, whether you were a battered wife or a combat veteran or torture survivor or a victim of crimes. There was a unified syndrome that could explain why you felt so transformed as a result of that experience. Stress effects don't always go away when you remove the stressor, that for some people, these effects linger. And what could be the biology that would help us explain long-term transformation? And one Holocaust survivor put it really well. She said, "I don't live in the past lives within me."
We hear a lot about traumatic brain injuries, both in the civilian population. There's a lot of sports injuries, football players, and negative effects of repeated concussions. It's a particular problem in people who served in Iraq and Afghanistan because there are so many blasts going off all the time. IEDs, there are rockets, mortars, these explosions are happening all the time. And so what that does is it doesn't necessarily knock you out, you're not unconscious, but you're just a little bit shaken up. It kind of can be the perfect storm where you develop the effects of the mild traumatic brain injury where there's no loss of consciousness, but you also develop post-traumatic stress disorder. When the two conditions occur together, we really don't fully know how to treat it, and we don't know whether the symptoms can be attributed to the brain injury, which is, you know, what we think of as like a physical assault to the brain, or the psychological assault, which can also have biological effects. You're going to give the treatment for the TBI, it might be something like a stimulant to help you concentrate better, you know, helps people to focus. But if you have PTSD as well, you might already be overstimulated or, you know, hyperarousal. You'd want to think very carefully about whether a stimulant is going to exacerbate those PTSD symptoms. So it really becomes a very important clinical question as to how we help people that have both conditions to think more clearly, but also to cope with the psychological effects.
The goal of these therapies is really to get the trauma survivor from feeling like they're victimized to feeling powerful, like they're a survivor, like they overcame something. Going from victim to survivor, that is the secret sauce of the psychotherapies for PTSD.
While some scars are invisible, others can be significant, especially if surgery is needed, which is why one Mount Sinai physician has pioneered a scarless robotic technique to remove the thyroid gland. In her own words, one patient shares her story.
My thyroid was kind of like there was a lump there, and then I was kind of, you know, feeling both sides, feeling that the one side was bigger than the other. They test it to see if it's cancerous because the first thing they think is if you have a nodule on your thyroid, it's likely thyroid cancer. It came back negative. And then that's when I went to Dr. Suh for the first time. He did an ultrasound and he recommended having surgery.
She had a very visible, benign goiter, thyroid nodule that has been growing more and more visible, and also had some compressive symptoms, and therefore she wanted to have this removed. But again, given her young age and the fact that she did not have an ideal skin crease in her neck, so any kind of incision in her neck would have led to a conspicuous scar. The typical thyroid surgery is they just kind of go right in through your throat and you have a pretty big scar. And I scar pretty badly as it is. I'm fair-skinned and I keloid scar. So I was like, I don't want this huge worm across my throat for the rest of my life. Luckily, this robotic surgery kind of minimizes the scarring. BABA stands for bilateral axillobreast approach thyroidectomy, where you make 4 small incisions at the armpit as well as the areola. And using those 4 small incisions compared to conventional surgery where you have to make an incision at the neck, we insert a robotic instrument to do the robotic thyroidectomy with the hidden scars. He said you might have small scars, but the incision that I make is literally like 2 centimeters. For someone who keloid scars, I can barely see my scars. Like, they're pretty much non-existent. In the few days after my surgery, and he would call almost every day to check in. He would ask me how was I feeling. He could tell that my voice was kind of shot, and he was like, don't worry, you know, this isn't going to be a permanent thing. You're going to have your voice back. Just make sure you rest and everything. So it was really great that I've never had a doctor who calls you at home and asks you how you're doing. So the biggest advantage at this time is the fact that patients will not have a visible or conspicuous neck scars. So it's mostly a cosmetic benefit. And for some patients that I've treated with who are either local singers or spokespersons who wanted to keep a confidentiality so that when they go back to work a week from the surgery, that they will have no scars visible. The BABA robotic thyroidectomy is good for both benign and malignant disease of the thyroid gland, including thyroid cancers, as well as a benign multiple nodular goiter or symptomatic or compressive goiters. The size of the nodule, as well as the stage of the cancer and the indications will vary depending on the experience of the surgeon, as well as the team that you're working with. I think this is a very exciting development, the fact that patients will now have an option of having a traditional surgery or having a hidden scar operation for even benign large goiter, as well as the advanced cancer disease. I asked Dr. Suh, I signed up for this half marathon in April, am I still going to be able to run it? And it was my slowest half marathon ever, but it's okay. At least I finished. It was very cool to be able to say, you know, I had surgery a month ago and I was down and out for a week, and now here I am crossing the finish line at this half marathon.
Birthdays are important milestones, and that's especially true for a 2-year-old boy who had a challenging start to life because of a rare heart defect. In our final story of the broadcast, Devin's family shares his heroic journey.
Happy birthday to you! Devin is an ordinary 2-year-old. He is energetic, independent, rambunctious.
He runs, he climbs.
He is our little tornado. It took us 4 years to get pregnant. We finally got pregnant. We're like, oh my gosh, thank God. We went in for the 17-week early anatomy scan, and we were sure that everything was going to be okay. And at the end of the appointment, they said, well, we've noticed that the baby's heart is slightly shifted in his chest. Your son has a congenital heart condition called tetralogy of Fallot. He will need open heart surgery. However, he is in tachycardia, and his heart rate is twice what his heart rate should be, and we need to get medication to him, we need to hospitalize you, and he is at risk of fetal demise. It's a time when you're pregnant and you're like supposed to be a peaceful, happy, beautiful, wonderful, exciting time. And I just felt unbelievably stressed. There were so many unknowns. We didn't know if he was going to make it.
At that early an age, at 17 weeks, to have a fetus in tachycardia is very, very rare. Normally we make this diagnosis much later.
Dr. Srivastava laid out basically the entire plan for us. We had a high-risk doctor, and our doctor was going to be there, and there was going to be a team of doctors and nurses from the intensive care unit that was going to take the baby away immediately to do all these tests. And then after he was born, we were told he wasn't allowed to cry, and we had to constantly be monitoring his oxygen levels, which, of an infant is not that easy.
I spoke to my surgeon and I said, really, I think we should just do the surgery. We shouldn't wait. And I'm really happy I made that decision that day. And he recovered very well from the surgery.
He is a kid who he falls down and he gets right back up and keeps going. Because of what he went through, it's almost like he has a real appreciation for life.
Thank you for watching Mount Sinai Future You. You can follow us on Twitter and Facebook to learn more about the incredible research and innovation happening here at Mount Sinai.